Hello, everyone, and welcome back to Karan Academy. My name is Karan, and today we're going to be kicking off our renal and genitourinary tract series with acute kidney injury. Now, I'm sure this is a topic you've come across in your preclinical years. However, it's one that is very commonly assessed and is really important to know. Now, the big part for AKI that was really a bit overwhelming for me in preclinical was the complexity of the different causes and being able to understand what's going on. Now, obviously, my whole purpose of these lectures is to add value to what you're learning. And a good metric that I've always used in the back of my mind is how many kind of big brain revelations can I have per lecture? And in my personal opinion, AKI is pretty up there. So at this point, you probably have heard of AKI. You probably have heard of the different types, but do you actually understand what's going on? And if your answer is no, that's completely fine, because that is why we're here, and we're here to learn. And if things don't make sense, that's completely fine. You have a long road ahead of you. So let's start with what acute kidney injury first means. So the acute bit means it has to happen usually over days to weeks. For chronic kidney disease, or for a kidney injury to be considered chronic, it usually has to be for more than 3 months. Now, what constitutes an injury? Because obviously we would be measuring biochemical markers. So what actually has to happen for us to say, oh, well, the kidney's been injured? And we can either have a rise in serum creatinine, that's 1.5 times the baseline. And it's important to know that when we say baseline, we're referring to that person's baseline. You can have various levels. Obviously, the baseline serum creatinine of a bodybuilder might be higher than that of a 60-year-old woman. And that's not pathological. Therefore, it's very important to consider what their previous baseline was. Or having a reduction in urine output is another big one. Specifically, we look for the number of milliliters you're able to generate per kilogram of body weight per hour. And having a level that's less than 0.5 is considered pathological. Normal level is usually between 1 and 1.5. Over time, you'll see enough AKI to be able to pick up the cause and tell, oh, this is because of dehydration, or this is because of glomerular nephritis, broadly. But one thing you always should be asking yourself as well, okay, they're dehydrated, but is that enough to put them in a kidney injury to this level? Do they have something else going on that might predispose them to having such a presentation? So always think of it that way. Here's a good schematic representation of the causes of acute kidney injury. And I like to think of it as pre-renal, renal, and post-renal. So let's break it down. Starting off with our pre-renal causes. So pre-renal causes are things that are going on usually systemically that affect renal perfusion. Now that's the big one. So renal perfusion is being affected. That can be either because you are hypotensive. This hypotension can be because of a few things. It could be because you have congestive cardiac failure. It could be because you have something called hepatorenal syndrome, and we'll talk about this in a second. Or you might have sepsis that's caused shock and hypotension. You could be hypovolemic, which can be either due to blood loss from elsewhere, or it may be because you are simply dehydrated. Lastly, you can also have vascular causes like renal artery stenosis, and this is a very big red flag to always look out for. So we talked about dehydration and blood loss. We talked about sepsis, congestive heart failure, anaphylaxis, because it would cause widespread vasodilation. I also mentioned hepatorenal syndrome. Now, you hear about hepatorenal, it's kind of one of those things that you keep hearing, but I don't think we really understand it. So let's briefly talk about why that happens. So you need to know that the liver is responsible for breaking down a compound called nitric acid. And if you know, nitric acid is a potent vasodilator. So what happens is with hepatic damage, you often have inadequate breakdown of nitric oxide. Because you're not breaking down nitric oxide and you're going to have too much of it, that's going to cause vasodilation. One of the complications of that vasodilation is going to be hypoperfusion to the kidneys, which is then where you have a renal syndrome presentation. And that's why it's called hepatorenal. There's also cardiohepatorenal syndrome, and you can have more, I guess, complex interactions, but that's one of the basic ones that is important to know. Then you might also have renal artery stenosis. And as the name suggests, it's basically a blockage of the renal artery. And the typical presentation for renal artery stenosis and typical bilateral renal artery stenosis is anuria. Now, what I mean by anuria is complete stoppage in the production of urine. And you typically have this in patients with familial hypercholesterolemia or too much cholesterol, which might predispose them to having a degree of stenosis. And then something like a medication, particularly ACE inhibitors, might just throw them off and push them over the edge and cause full-blown bilateral renal artery stenosis. And that's a huge, huge red flag that you always need to consider. Now coming to the interesting bit. These are our renal causes of AKI, and it's really important to know them. So when I think of renal causes, you could just go ahead and memorize this list, right? So you have glomerular, tubular, interstitial, and vascular. But I think if you understand the components and what's actually going on the microscopic level, things just make a bit more sense. Starting off with our glomerular causes, right? So let's start off with glomerular causes. Now, glomerulonephritis, relatively straightforward one. You have an inflammation of the glomeruli, and we'll talk about the different glomerulonephritis. Minimal change, FSGS, we'll talk about them in another lecture. They deserve their whole own time. Or other causes of glomerular AKI would be things like diabetes, because you know that within the glomeruli, you're going to have glycosylation of the Bowman's capsule and of the glomerular tissue because of those high concentrations of glucose, and that's going to be inflammatory. Lastly, you can also have things like amyloidosis, and with the deposition of amyloid, the first place that's going to go within the kidney is the glomerulus, and that's where you have amyloid-based protein damage, which would be affecting the glomeruli. Next, we can have renal tubules, or well, the next component of the nephron are the renal tubules. And if you have something going on in the renal tubules, then that might also present with an intrarenal cause. I also realized that as I switched the side, I said understand this, then I said suss this out. I obviously forgot to change that here, and I'm too invested in this particular recording to restart, so I will keep going. So we have renal tubules. So what can be happening at the renal tubules? You can have acute tubular necrosis, and as the name suggests, you are having necrosis of the tissue, which is most commonly ischemic in nature. So you have something that's disturbing the blood supply to these tubules in most cases. And then going on to just interstitial stuff, so everything around the tubules, you won't really infarct them, so you don't really have interstitial necrosis, but you can inflame it. So you have acute interstitial nephritis, where you have inflammation of the tissues surrounding the tubules and the entire nephron. So with glomerulonephritis, we know that it can present either with nephrotic syndrome, nephritic syndrome, or rapidly progressing GN. And obviously, RPGN is going to be the worst one to have. And we'll talk about all these presentations in another lecture. It's relatively easy once you wrap your head around it. I particularly like GNs, and I like nephrology as a whole. I know that's a very controversial opinion to have sometimes, but I think once you understand them, they're relatively easy. And I talked about diabetic nephropathy and amyloidosis. Now, acute tubular necrosis, you, as I said, have necrosis of the tissue. That can be either ischemic or because of certain toxins that might just cause the cells to die. With ischemia, it's often a sequelae of pre-renal AKI. Now, what do I mean by this? Obviously, pre-renal AKI just means that you're not perfusing the kidneys enough, and that's going to cause kidney damage, right? A component of that is going to be, obviously, with the blood supply going to the kidney, you also have the cells within the kidney that need their own blood supply too, right? Particularly your tubules and your entire nephron vasculature as well. So if you aren't supplying the tubules with enough blood and oxygen, they are going to undergo ischemia and necrosis. The tricky part is that you, in these patients, would then fix the pre-renal cause, give them some IV fluids, fix their hypotension, but they still don't recover well, and they still seem to have high levels of serum creatinine. And you might be wondering, well, what's going on there? And typically, that indicates that you might have had some damage to the actual tubules, typically ATN or acute tubular necrosis, which is now causing that presentation. You can also have toxins, which can either be endotoxins, which are just the toxins generated endogenously in your own body, like myoglobin with things like rhabdo, or endogenous toxins, particularly antibiotics, gentamicin being a big one. From a diagnostic perspective, in the acute setting, it can be really hard to distinguish, let's say, an acute tubular necrosis from pre-renal AKI, because you might be thinking, well, both of them would be based on hypoperfusion, and how do I make that distinction? We'll talk about that in a second, but just based on that clinical presentation, I want you to just realize how that can be a bit challenging. Next, we have acute interstitial nephritis, and this is an inflammatory process compared to an ischemic process in ATN. And it's mostly by drugs or systemic diseases. So drugs like penicillin and NSAIDs are big ones. And then diseases like SLE, sarcoidosis, and HIV can be causes of inflammation everywhere in the body, but particularly in the interstitium of the nephrons as well. Okay, now, you might be wondering what the cause of intrarenal AKI is. As I mentioned, antibiotics, right? You can have antibiotics being both a cause of ATN and as well as AIN. That distinction is often pedantic. If you can identify an agent, then great. But in most cases, you won't be able to narrow it down to the exact cause unless there's something pointing towards it. But that shouldn't really be a big concern for you, because the management or the basic principles of how we treat AKI are going to be relatively the same. Now, what are post-renal causes? Now, post-renal causes basically refer to some issue in the ureteric system that obstructs the flow of urine. Now, why is this important? When you obstruct the flow of urine, that's going to cause backflow. It's going to cause increasing pressure. And as you can imagine, if you're applying pressure in the other direction, that's going to damage the kidneys in the short term. And it's going to cause the leakage of various metabolites, including things like creatinine and urea, into the bloodstream. Most causes are at the level of the bladder and below. So things like urethral strictures, BPH is a very big one and important to consider, as well as prostatic cancer. Why is this the case? Why don't ureteric pathologies usually present with a similar picture? Well, it's very unlikely that you're going to have issues on both sides, right? Because if you have an issue on one side, well, that can obviously cause hydronephrosis for that particular kidney, but it's unlikely to affect both. And usually, in the short term at least, your kidneys can compensate relatively well for such things. But you can also, as I said, never say never. You can have congenital pelvico-ureteric junction obstructions, and that is a common that's a common site of narrowing in the ureter and can be obstructed. And you can also have bilateral nephrolithiasis or kidney stones. At this point, I'd probably be investigating some other conditions that can put you at a risk of kidney stones, but obviously a very rare occurrence. The hallmark of post-renal causes is going to be a hydronephrosis that you can see on an ultrasound of the kidneys. So it's usually it's called ultrasound of the KUB, so kidney, ureters, and bladder. What's special about post-renal causes is that they are relatively easy to pick up. Now, most cases are going to be, as I mentioned, urethral strictures, BPH, and prostatic cancer, or even rarely, things like kidney stones. Your patient is going to know that something is happening, and it's going to be relatively obvious. They might have an enlarged prostate. And again, because there's a complete obstruction, it's likely that they're not going to be peeing out much. So when was the last time you went? Do you have any pain? All good questions to ask. Before we jump into investigations and talk about how we can use many of those tools, a few important points you need to know. Anuria or no urine over a 24-hour period is a huge red flag. It indicates that things have gone horribly wrong, typically. That can be because of two causes. The first is something called, we already talked about this, so bilateral renal artery stenosis, and that's a vascular catastrophe, as I've heard a nephrologist once say. It's really, really bad. It's like a heart attack to your kidneys. And then you also have your post-renal causes that might cause a complete obstruction. So urethral strictures, BPH that's gone off the charts, and so on. Oliguria or reduced output, as I mentioned, is a very typical hallmark sign, typically less than 0.5 ml per kg per hour for more than 6 hours. But anuria is a rare occurrence. The other thing is you can have, yep, already talked about that. Cool. And always check the urine, because the urine, as nephrologist says, liquid gold. So let's go on and talk about the investigations we can do. And here we have a few big brain moments as well. So splitting up our investigations into our bedside, bloods, and imaging format. Bedside, we can do an ECG, urine MCS, and urine sodium and osmolarity. Let's talk about the ECG, because I think it's relevant. With AKIs, you can have acid-base disorders and electrolyte imbalances, particularly hyperkalemias and hypercalcemias. Both of them can present with arrhythmias and ECG changes, which is why we like to do an ECG. In terms of a urine MCS, we want to rule out infections, but we can also look for things like casts, and casts can tell us a lot of information, which we'll see on the next few slides. Urine sodium and osmolarity is a very big brain test that I'll talk about in a bit. So how does hyperkalemia present? Well, it presents with peak T waves, a longer PR interval, as well as broad QRS complexes. So always look out for hyperkalemic ECG changes. In terms of casts, RBC casts are typical of nephritic syndrome. Having protein casts usually indicates that there's some disease that's causing excessive immunoglobulin production, and that's typically multiple myelomas, which can present with an M spike on electrophoresis. Brown muddy casts usually indicates acute tubular necrosis. The way I like to think about this is, once your tubules are kind of necrosed and dead, the only place that they can actually go, because your body is going to try and replace dead tissue, is pass through the tubules themselves. So it's kind of like the bricks of the wall fall into the tube, and then they eventually get excreted out, and that presents with brown muddy casts. You can also have inflammatory cells or inflammatory casts or WBC casts, typically seen with acute interstitial nephritis. And then hyaline and granular casts don't mean much. They just indicate that there is possibly some fibrosis going on and some level of renal injury. Now, let me take the next 2 minutes to talk about urine sodium and osmolarity, because it's an incredible test. And here are some RBC casts. If you see an RBC cast, usually think, could this be, so this is meant to represent the shape of a tubule. So you had bleeding into the tubule, that's how it's accumulated, and which is why it's all clumped together. And here's what a muddy brown cast looks like. There are some other casts, but you usually would not be expected to know what they look like. So that's, I guess, good to know. Those two, though, I would recommend you would know. Now, urine sodium and osmolarity. If you've zoned out, take a second to get back, full attention, because this is big brain and it's relatively important. Urine osmolarity is a reflection of the kidney's ability to make urine, right? It's based on everything in the urine, not just sodium, right? So this includes your creatinine, your urea, your various toxins that you produce, ammonia, and so on. So it's got a whole bunch of stuff in it. Now we have the level of sodium in the urine that should represent the body's hemodynamic status. Now let me explain what this means. Your kidneys do a really good job of maintaining your blood pressure, right? Obviously, you would have a situation where you would normally be consuming a lot of water, and doing fine, but in some cases, you might not be having a lot of water, right? How does your body cope with that? So you know that water follows sodium. Let's say we have a case, Paul, who is a very keen medical student, has been working with the surge teams, getting his reference letters, and has not been drinking enough water. He's going to be dehydrated, and he might have low intravascular volume, right? He just doesn't have enough water in his vessels. The kidneys, which are perfect at picking this up, what would they do? Well, they basically will try to get more water into his vessels, and they would do that through sodium. Because if the kidneys were to reabsorb more sodium into the vessels, well, they know that water is going to follow sodium, and you're going to have now more water in the vessels. And that's great, because we want to do that. So what will you see in the urine now? Will you see higher sodium or lower sodium? Well, it kind of makes sense that if you reabsorbed the sodium, you're going to have low sodium, right? But at the same time, although your sodium is going to be low in the urine is going to be hyperosmolar. Take a second, I'll say that again. Although you will have low sodium in the urine will be hyperosmolar. Why? Because you are now still secreting all the urea, all the metabolites, but with less amount of water. Because again, with the sodium, you also absorb a lot of water. So your urine is going to be very concentrated, right? Or hyperosmolar. Does that make sense? Right? Rewind, listen to that again, read through this if I did a horrible job of explaining that. But when you have a situation where you might be dehydrated, which is your typical pre-renal cause of AKI, you might have low sodium, or you will have low sodium and hyperosmolar urine. Meanwhile, if someone had a renal cause for their AKI, so the issue is at the level of the kidneys where the kidneys are not functioning, what would you see? You would see that the kidneys are no longer able to reabsorb the sodium back into the vessels of the body. And so all of it will basically leak out through the urine. So you would have high sodium levels in the urine. And at the same time, because it's not concentrating, you're going to have low osmolarity. Because again, the kidneys have done a horrible job of reabsorbing the water. You just are peeing out water at this point, right? And you're going to have urine that's going to have a low osmolarity for that reason. Does that make sense? So pre-renal cause like dehydration, low urine sodium, high urine osmolarity. Renal causes high urine sodium and low osmolarity. Does that make sense? And that's a really good test you can do to actually differentiate renal from pre-renal causes. Because as we mentioned, that distinction might be a bit hard to do. Now, the blood urea nitrogen to creatinine ratio does something very, very similar. It's very similar. I'll explain that too. You have two components. You have urea and you have creatinine. They're both freely filtered, which means both of them pass through the glomerulus freely. But urea is readily absorbed with water, while creatinine is not. What does this mean? Right? So for reference, I'll just say that the normal ratio of blood urea nitrogen to creatinine is about 40:1 to about 100:1. Again, if the issue is pre-renal, as I mentioned, like dehydration, the kidneys are going to be absorbing a lot of water back to try to keep the BP up. And because urea is readily absorbed with water, you're also going to pull back urea. So now the blood urea nitrogen to creatinine ratio is going to be high because you have too much urea in your blood. Important to know that when we talk about the blood urea to nitrogen test, that's a blood test, while the urine sodium and urine osmolarity test are going to be tests on the urine, right? So remember that. So again, if the issue is pre-renal, you absorb water. With that, you pull in the urea. That is going to raise your BUN to creatinine ratio. However, on the flip side of that coin, if the issue is with the renal tubules themselves and the tubules can't absorb the water, the ratio would drop. And that's going to be usually less than 40:1. Keep in mind, we are purely looking at the ratios. In both cases of AKI, you will have both urea and creatinine levels in your blood rise. I'm not saying that creatinine is cleared more, but it's relative, right? With, let's say, pre-renal AKI, yes, the creatinine will also rise in your blood, but the BUN will rise significantly higher than the creatinine, which is why we look at the ratio and not absolute levels. Hope that makes sense. So how do we treat this? We want adequate fluid management, so fluid balance charts, a fluid restriction if the issue is renal. And this is typically where the patient might be fluid overloaded, and we might want to restrict their amount to usually 1 to 1.5 liters of fluid a day. Obviously, you would not do this if the patient is presenting with hypovolemic shock, because you would practically do the exact opposite of what you're trying to do. And you might consider putting in a catheter. A catheter is really good for two reasons. Firstly, if the issue is at the level of the urethra, that can help relieve the post-renal obstruction. And secondly, with a catheter, you can have a very good estimate of their fluid intake and their fluid outtake. And that is important for fluid balance chart. So you know how much has gone in and you know how much is coming out. You want to stop any nephrotoxic drugs. So antibiotics like aminoglycosides, penicillins, and cephalosporins. You want to stop ACE inhibitors and ARBs, as well as aspirin and NSAIDs. All of them can contribute to vasoconstriction, as well as inflammation and necrosis at the levels of the tubules and interstitium, respectively. In saying this, I will acknowledge that I have talked about how good ACE inhibitors usually are. And yes, I would be the first to tell you that if the issue was that of a chronic kidney disease, please put them on an ACE inhibitor. But don't do that if it's an acute kidney injury. That's the distinction. If the issue is pre-renal and that of dehydration or hypovolemia or some kind of shock, whether that's cardiogenic or hypovolemic, you want to start them on IV fluids. And that's typically going to be your 0.9% saline. And you want to treat any complications that may arise from that. Those complications namely include hyperkalemia, and you would do that by monitoring an ECG. If it is resistant and not improving, you might consider insulin and dextrose. Why do we use insulin and dextrose? We use insulin because insulin works on the sodium-potassium pump and pushes potassium back into the cells, which is good. Why do we give them dextrose? We give them dextrose because, well, we're giving them insulin, and insulin, as you know, would lower the blood sugar as well. So by giving dextrose additionally, we are making sure that we are just getting the potassium into the cells without affecting the blood sugar level significantly. We can also give calcium gluconate, which doesn't actually reduce the levels, but it stabilizes the cardiac myocytes to prevent arrhythmias, which is one of the big reasons we're worried about. We can also give resonium, which is a chelating agent, commonly used to prevent the absorption of potassium through the gut. If they're fluid overloaded or have APO, we want to start off with our LMNOP management, and we've been over this in cardiology, so I won't go through this right now. And lastly, you might consider dialysis. And the indications of dialysis, and I talk about this in our lecture on renal replacement therapy, it's going to be AEIOU. So acidosis, electrolyte disturbances, which you can see here, intoxication, fluid overload, and uremia. That is all we had for AKI. I hope that helped. I know this is a bit of a confusing topic, so please don't be stressed if it doesn't make sense the first time around. I promise you it will. If you have any questions, please feel free to get in touch. I'm always happy to answer any questions. And please look after yourself and please look after your loved ones.